Well, good afternoon, everyone. I'm Alice Park, Senior Health Correspondent at Time, and it is my pleasure to be moderating this session on the global health crisis. So I thought we'd start with some introductions. To my immediate left, Aloe Blacc, singer, songwriter, philanthropist. Sheila Davis, CEO of Partners in Health. Sofia Gruskin, Director of the USC Institute on Inequalities in Global Health and Distinguished Professor of Population and Public Health Sciences and Law. Next to her is Marì Beth Powers, CEO of the Catholic Medical Mission Board. And finally, certainly not least, Dr. Tlaleng Mofokeng, UN Special Rapporteur on the Right to Health. So Dr. T, as she'd like to be called, will be giving a keynote. We'll start with that, then have a discussion, followed by some Q&A. So feel free to raise your hand and ask some questions at that point. So Dr. T, the floor is yours.
Thank you so much, dear colleagues. It's a great pleasure to be able to address you this afternoon on global health issues and epidemic preparedness, especially looking at the challenges and opportunities during the recovery of the COVID-19 pandemic. Now, the realization of the right to health is more than just about the realization of access to in-facility care. But whether before or during or after a public health crisis, it requires all human rights to be fully embraced. It's an inclusive right that extends to also underlying determinants of health. Therefore, the prevention of public health emergencies addresses civil, political, economic, social, and cultural rights and ensures that health promotion is available, accessible, and acceptable to everyone. The indivisibility and the interdependentness of human rights became obvious during the AIDS epidemic, and it remains important as the world faces the COVID-19 pandemic. Among the fault lines that were highlighted by the COVID-19 pandemic, drastic inequalities continue to exist in health, and access to health care are among the most prominent. Almost everywhere in the world, the poor, minorities, and vulnerable populations have been far more susceptible to serious illnesses and death from COVID-19. Effective health system responses, whether in policy and law, at all times, including in a global pandemic, require access to information for all people and meaningful participation and accountability mechanisms. Decisions to suspend or curtail certain human rights in response to a pandemic must be made in accordance with international law, and the decision makers must always be held accountable. The COVID-19 pandemic deepened fractures in health systems around the world and further exacerbated barriers, for example, to sexual and reproductive health rights. In many parts of the world, the COVID-19 pandemic emergency measures resulted in amendments in laws and social contracts directing the movement of people, but there have also been opportunistic uses of these circumstances to implement draconian measures which further curtailed human rights, especially relating to adolescent girls, women, and LGBTQA+ persons. We know in the immediate time that resources were diverted in clinical services from sexual and reproductive health related resources, such as abortion services and family planning, and clinics for adolescents and LGBTQA+ needs, as well as gender-affirming health care towards COVID-related services. And such services in many health systems have not actually been reestablished. And so we look back on the COVID-19 pandemic with much to answer for, and though brutal and unexpected, there were many opportunities to do things the right way and truly put the human beings first. The extraordinary speed in which the production of safe and effective vaccines for the COVID-19 showed that in fact there is capacity to respond timelessly in the face of some of the greatest challenges to humanity. The scientific progress has, however, not been followed by swift action to ensure equitable access across all countries and all regions in the world. And unfortunately, we saw yet again how maximizing profits and unfairly protecting industry led to protracted negotiations and extensive blockages to the TRIPS waiver resolution that was proposed by South Africa and India with the aim of making vaccines more equitably and expeditiously available. When it comes to corruption in the health sector, we have to focus on some of the institutional but also political corruption and how these have negative impact on the availability, accessibility, acceptability, and quality of healthcare. The AAAQ framework for the right to health is particularly important to truly leave no one behind. And corruption is unethical and transgresses medical and ethical standards and has a devastating effect on good governance, the rule of law, and equitable access to public goods, services, and facilities. And we know that all human beings have a right to benefit from scientific progress, and yet we see the actions or the inactions of some state actors, non-state actors, but specifically businesses, and how corruption in the business sector has yielded negative health outcomes in the health field without any consequences. Large funds of money will be made available in future for pandemic responses and emergencies, and therefore it is crucial that transparency and accountability are adhered to by all stakeholders within countries, but also within a global community as part of international solidarity. We need more than just promises. We need binding and implementable treaties, which at its core lies human rights principles. Human rights are a language of obligation, and rightly so. The International Covenant on Economic, Social, and Cultural Rights articulates clearly what are the state's obligations under the right to health in order to make sure that the right to health is realized for all during, after, and of course in times of crisis. The COVID-19 pandemic also brought to the fore disability rights, the rights of the child, the rights of LGBTQA+ persons, the rights of migrating communities, the rights of internally displaced people, the rights of Black and Indigenous peoples. And so it is imperative that the cost of managing and coping with the social, financial, and mental and long-term health impacts of COVID do not fall on individuals. The individuals who are already pushed to the margins by some form of structural or systemic discrimination, but that they are well supported by healthcare and other social services as well. And states have an obligation to help those that are seeking access to rights-based treatment, care, and support, including user-led provision of healthcare. Health inequities can never be overcome by healthcare systems alone. The underlying and social determinants of health extend beyond the healthcare sector. And many of these major poor health, mental, and physical health outcomes arise from violations of other human rights, including to equality, dignity, security, and equal participation in society. And therefore, as a proposal going forward, is that we ought to be working together for substantive equality, which must be understood in the context of the historical injustices that necessitate them. That these solutions aimed at achieving equality, therefore, cannot be ignorant to the position within the social power matrix that people they want to serve. The right to health relies on public participation in health-related decision-making at community, national, and international levels. But this is increasingly becoming a challenge given the private sector influence over these processes and spaces, even within the United Nations itself. And so I remain particularly impressed by the role that civil society has played in this particular COVID-19 pandemic in galvanizing all of us to the call to end what we have then called vaccine apartheid. And as a South African, a child at that time, a survivor of a brutal colonial apartheid regime, and now an adult in a democratic South Africa with the mandate of the UN Special Rapporteur on the right to health, I know, like my life, the future of all people everywhere around the world cannot depend upon a series of perfectly aligned miracles. As a practicing medical doctor, I know the enduring intergenerational trauma, the physical and mental health impacts of racism, structural discrimination, as well as violence. And while the global radar is on humanity's overcoming of the COVID-19 pandemic and preparing better for the next biological challenge, we cannot stand by while other human rights violations occur. And during my tenure as a mandate holder of the UN, I have intervened in amicus briefs, including the Roe v. Wade SCOTUS case, in different governmental and judicial processes around the world, and have sent some public, some private communications to member states of the UN on urgent appeals to prevent human rights abuses and violations, including also to businesses and other non-state actors. I continue to stand with all people who live under the crushing weight of suffering, intense and protracted war and conflict, the people of Haiti, the people of Congo, of Yemen, of Palestine, of Syria, of Sudan, indigenous peoples everywhere, who under the prevailing coercion violence, their right to health cannot be realized. A rights-based approach requires simultaneous attention to immediate health interventions and the longer-term social transformation required and progress in the COVID-19 recovery period. It must be monitored and met with the necessary agility of the health system, but also political leadership. We need racial and economic justice. We need climate justice. We need to affirm the right to a system of health that provides an equality of opportunity of everyone everywhere to the highest attainable standard of physical health. In closing, COVID-19 not only intensified the human rights violations that were already happening, but it also acts as an amplifier, a magnifying glass, or an X-ray of sorts that reveals the immoral social structures that are still present in the world today. The question is, why did all of the international human rights standards and laws and consensus not work and protect those most vulnerable at the time when they need it the most? It's a question we can ask today. Why everything we have in space in the multilateral system not able to prevent a genocide? This is not a surprise to those of us who suffer from these systems, but it can and should be an opening of the eyes to those who are responsible for them. Thank you very much.
Thank you, Dr. T, for the remarks. They really lay a great foundation for our discussion this afternoon, I think. Mary Beth and Sheila, let's start with you. Both of you had teams on the ground during COVID, on the front lines during the pandemic. What, in your view, what were you hearing from them about some of the biggest challenges they faced as soon as the pandemic started picking up?
For us, it was the shortage of PPE, so there wasn't personal protective equipment here, there wasn't globally, and then very rapidly shortages, it all being used up in northern countries, so there wasn't very much available in southern countries. We eventually got to places where we had people making hand sanitizer locally. We had a lot of creative solutions, just like health workers faced here. That was a key issue for us. I think mobilizing people, we were very involved in mobilizing people for vaccination campaigns in both Haiti and in South Sudan, which was an incredibly difficult place. And you probably heard the stories that at first vaccines were delivered there, nobody was ready, there wasn't a plan to deliver the vaccines, and then Haiti also turned down the first set of vaccines that were offered. So there are a lot of complications with just readiness, preparedness, which I think is part of what you were getting at, Dr. T, in terms of like if we're thinking about the future, like how prepared are we for the next pandemic, because there will be one. I think we heard some good advice this morning, but it's also, you know, even having supplies in place, et cetera, there really needs to be a plan. And the systematic underinvestment in health systems and in public health systems in particular is, I think, probably the biggest problem and the greatest learning for us through the COVID epidemic. And then how are we going to address whatever comes next? So I'll leave some space, Sheila, for you to add some other things you guys saw.
Also, in terms of oxygen supply, I think what COVID did was illuminated that there's a huge lack of oxygen systems in many of the countries we work. We work in 11 countries around the world, very poor parts of those countries. So the fact that there wasn't the ability to have an ICU because there was no oxygen was huge. Also trained healthcare providers. I think, you know, our whole premise is partnering with the public sector to build a sustainable health system, and that includes training healthcare providers, but critical care is one of those things that is taking a long time to catch up. So the fact that even if we had oxygen supplies, had a ventilator, it was rare that there was the providers able to actually provide the highest level of care. So I think, you know, the end result, I think, was sporadic help, which is what often happens. Also the fact that it was the world was shut down. There was not the ability to have people go and help in the same way because of travel restrictions, et cetera. So just as unfortunately always happens, the countries in which we work were kind of left. I think there was also places where we were ready to get the vaccine, but there was the assumption that we couldn't do cold chain. Mm-hmm. We could do cold chain because we had worked with the governments to improve their supply chain for years to make that happen. But I think that was also decisions made by people who did not know the local abilities or have the local context. So I think what we really tried to do is utilize the COVID money to strengthen the health system we're already working in, building oxygen plants, building oxygen supplies, and I think the world really saw that the lack of oxygen was probably the biggest, resulted in the biggest mortality around the world, which was really unfortunate because it's cheap, it's easy, and that doesn't need a trained health professional.
I think the issues that you raised on supplies, on workforce, and the issues that Dr. T raised about prioritizing humanitarian principles, human rights principles, really kind of gets right at that, right? Because what we're seeing is a system that has built on the inevitable correlation between a country's economic status and their ability to have good health outcomes. I wanted to ask all three of you, do you think that that's inevitable? Does it have to be that way? And particularly maybe Dr. T, if you see a vision for moving forward where we don't see that inequity based on economic status.
So I think the issue of economic status, you know, it was emerging early on as a determinant, and it was more of a historic issue because you had people who were historically living in segregated communities because of class issues. They were living in areas that were already having air and water and land pollution, which were already leading to chronic respiratory illnesses. And so with the COVID being a respiratory illness, that happened and it became more severe for them because they're already having other unmanaged or undiagnosed and poorly treated respiratory illnesses. And so that became an issue of how do we look at how communities are actually structured and who lives where. And that's where the issue of, you know, coming from South Africa myself was such a thing that I immediately understood. Because if you go to the southwestern townships in South Africa, a lot of those communities are living on old mines that the mining companies actually didn't do due diligence in terms of recovery and clearing up of all of the toxins and do the right thing for climate and for the environmental health. And that's having a direct impact on people's health. And that worsened during the pandemic. And so when the regulations were about, you know, social distancing, you know, use an extra room if you have a health worker in the house to isolate. When you're already living in a 2-bedroomed house, there is no extra room for the mom who's the nurse to isolate, right, and monitor his symptoms. So there was a lot of that difficulty that we were having to help people with. The reality of, yes, the guidelines are saying one thing, but in reality, when you're looking at class and you're looking at what people can afford, they were already not affording these basic things anyway. And so what does it look like during a pandemic? And what is the role then of the state to ensure that underlying determinants such as safe housing and health environment as well? And so my advocacy actually ended up being more outside of the health system and being more out there with other ministries to get them to actually give people housing, even if it was temporary, and those measures had to be in line with what was emerging, that we knew, social distancing was important, hand washing, access to water, fresh running water was an important issue for many people. So that socioeconomic status became a determinant once again of who lived and who died. Because again, when you need to take a public transportation, which is an hour away from your nearest clinic, it's quite a thing when you're in respiratory failure, when you need immediate oxygen, that you can't even get to the oxygen. And I think these infrastructure issues as well are important to discuss in terms of the state or government's responsibility outside of the health system to make sure that people can actually get and gain access.
And this is why you were referring to the fact that healthcare needs to go beyond the health system, right? As we need to think beyond just hospitals and doctors and nurses. Sophia, I wanted to ask you about the pandemic treaty, pandemic accord, whatever we're calling it now. We heard this morning from Zaid Rad Al Hussein, who raised a lot of sticking points over this treaty at this point. And it seems like the treaty's intent is to address some of these issues that, for example, Dr. T brought up, that Mary Beth and Sheila brought up, and make sure that the system we have in place is going to prioritize equity and access to quality care. Tell us where we stand with that, and I guess your assessment of how optimistic you are that we're going to get something that is going to make a difference before the next pandemic.
Okay. All right, here we go.
Big question.
Okay, yeah. Okay, I want to start by saying something, and I really resonate with everything everybody has said, and I think the word I want to bring up right now is politics. And health is political, right? And we just have to admit that who has access to health is political. And the way that politics plays into this is something that is critical in terms of what happens on the ground, but it's also critical in terms of thinking what's happening with the treaty. And so one of the things in terms of what's happening with the treaty right now, and I want to raise that ultimately, no matter how technically sound what language we put into the treaty is, the fact of what language actually gets agreed to be in the treaty is based on politics. And it's based on how governments are speaking to one another, let alone once it is that the treaty is drafted, who signs up to it is also based on politics. And the extent to which governments actually do what they sign up to do is also based on politics, right? So I'm gonna start in kind of the bad, right, in that way. One of the things that I'm really concerned about now is that, just to completely resonate with what you said, I mean, you called it vaccine apartheid. I'm totally with you, right? I've been saying, sitting in this country, this me too, this like me first approach to vaccines,
Right.
which was, yeah, sure, of course other people should have it, but we should have them here first.
Which
right?
we saw,
Right.
and that was the policy.
100%,
Right.
right? And we have to admit that, right? And we have to see like how that played out and the way that and we have to make sure that never happens again. Right? That is our collective responsibility, right? And that's why I really believed in this treaty and why I really thought that this could really make a difference. But what's happened is that, and it's very much what was spoken about this morning and what you talked about, is that all the language that would bring human rights or equity or solidarity into it in a technical way as well as in a legal obligations way keeps being pulled out. And so we're going to have a treaty. We'll have a treaty. Well, actually, what we're going to have is we're going back. I mean, I think probably people in this room know that we almost had a draft agreed to. Right. And then where we're at now is that we're going back to something to be negotiated to think about what a draft could be. And so we are at least a year. We don't have a year. And we're at least a year from that, but that will require governmental commitment and agreement in order for it actually to make a difference, which is why I come back to politics.
And one of the sticking points is this idea of differentiated responsibilities, right? Where, countries that can make the vaccines, can make the treatments, have a responsibility for making sure that they are distributed equitably and that people in the world who need them will get them. How optimistic are you that that's a concept that all countries are on board with?
Not so much. just to start with, but I want to say something else. I mean, I think one of the things to talk about is a number of African governments have made it really clear that the capabilities are not only in the countries where things have been produced. And the question is, what understanding and agreement does the global community have about understanding where actually vaccines can be produced? And one of the things that is really of concern, I mean, I'll speak, and I think, Tlaleng, you'll speak to it more than I can, in terms of the number of countries, that there are countries on the African continent that have the capabilities to do so.
South Africa being one of them, right?
And the issue being the way in which what ends up happening is the way in which every time it seems as though the product and the ability to be able to work with those products exists, they get pulled out, the rug gets pulled out from under. And unless we get into a circumstance where we recognize the capability of more countries to be able to produce vaccine and not only to receive vaccine, I think that's something that we really have to get our heads around if we're really serious about global solidarity. So am I optimistic about the potential? 100%. Am I optimistic about it happening? Not very much.
Dr. T, I wonder if you could comment, being from South Africa, where there is a very strong now, genetic sequencing landscape. How is the fact that, as Sofia pointed out, that there is still this sense that, there are countries that can produce vaccines and countries that can't, or that shouldn't, right? I think is probably the more accurate word. Is that still paternalism? Is it science? What's behind that? If we have the science, if we've got some of the best genome sequencing centers in South Africa, why is there this sense still that, vaccines should be produced in the West, in countries like the US and the UK?
Yeah, and what had happened, of course, at the time, we were all excited that South Africa is going to produce vaccines. But what actually ended up happening is that the actual science and the know-how was still being kept a secret. And that was happening elsewhere. And the only thing that was happening in South Africa was the final packaging and distribution of the vaccine, which is totally different from producing a vaccine. And I think that's the inequity again, and the business dishonesty, I think, that happens with these kinds of contracts, and why we need to be reminding businesses of their own obligations to human rights. Often they don't think they have any responsibility to human rights. In fact, the UN has a guiding document specifically on business and human rights. And so for me, one of the bigger interventions during the pandemic was actually a lot of work with pharmaceutical companies and non-state actors in this regard. I think there is a lot in global health that we talk about inequity in health outcomes, and we're looking what's happening on the ground, but we don't often talk about the inequities around the table, that even if we're all around that same table, we are not all seen as colleagues and equals and peers. There is still a hierarchy of power depending on where you are coming from, global south, global north. That's why I'm so eager to get out of these labels of global south, low in middle country, because I find them also, just by the way that things are defined, they carry also some racial stereotypes as well about people's ability or not ability. And so global health is not exempt, right, from that same paternalism you're talking about, and the same racism that we talk about in the world. And when you saw, India and South Africa pushing really hard with the draft resolution for the TRIPS waiver, you can imagine what happened behind the scenes diplomatically to ensure that South Africa and India actually do not push forward with that agenda. Had they done it, it would have been a major win. And South Africa, by the way, has done this before with the HIV/AIDS drugs and generic manufacturing of drugs and pricing and all of that. So for us, it's almost like, we know how to do this fight of advocacy. But again, the politics. What else is going on behind the scenes that we do not know? And that's why civil participation is so important, and transparency is so important. Who is making the decisions in global health and who is setting the agenda? And without civil society there to ask the question, to demand the answers, and to ask for accountability, we will, like today, still be guessing what happened with the TRIPS waiver. Why did India and South Africa look like they're neglecting that? We know it was political pressure, but we don't have the proof. And every single door to civil society participation was closed during COVID at all of the international multilateral institutions, all of them. The surveillance, all of them were closed. And that was, for me, the first signal that something horribly wrong is going on here. And so the fight for that civil society participation, for me, is almost like a litmus test to know where we are in terms of things. And that was one of the first signals that indeed we are not on good waters here.
And speaking of the politics, I mean, it's worth remembering that South African scientists were the first ones to identify the Beta and Omicron variants and
Got
conduct
punished,
clinical
right?
trials.
Yeah, got punished for it.
And then it became, right, exactly, then it became stigmatized, right? Because, oh, this is where the, you know, the more worrisome variant is coming from.
And this is the hypocrisy of the world, right? The others would get awards for that kind of discovery. We get told, well, you can't come here for another year.
Right.
Stay there with you, you know?
Right.
Yeah.
And when you look and you track the travel, we never traveled
Yes.
anyway, right? It was always coming from somewhere. So, and that's the thing. Depending on where you are and who you are, you know, you get rewarded for particular things, and you know, and some
There's
things
a
are
double
looked at as
standard.
excellence and scientific discovery, and it's benefiting the world, and yay. And on the one hand, it was, oh, thanks for telling that to us. More travel bans, more this,
Yeah.
more that, and so it didn't help. It didn't help many of us in that instance. And I think for me, it talks a lot about what does true solidarity look like. You know, we often hear, you know, countries talk about their foreign policy. They talk about international cooperation, and so what does it actually mean, and what does it look like? And you will find that what politicians are doing and saying on their behalf of their citizens as foreign policy is very different from what citizens would want the governments to be doing on their behalf. And so what does citizenship and what does active citizenship look like? And how do we get our leaders to be more responsive in the immediate to what it is that the people want? I'm not trying to start a revolution, but I'm just saying that it is important that we remember that the people have the power to elect leaders, but we must hold them accountable. And when they don't do what they're meant to do, or when the mandate exceeds their own capacity, they need to leave. And we must get new leaders who can get the job done, because we can't all be held ransom in global health by poor leadership. And I mean this truly, in every global health institution, including the UN, right? We can't all be held ransom to poor leadership. If you are truly cannot no longer take us where we need, it's okay to step aside and let the people who can take us forward do so.
So, Aloe, we haven't forgotten you. I want to step beyond COVID for a moment and talk to you about, you come to this world from a very different place as an artist. And clearly for you, these issues, challenges must stand out even more and, you know, make you question, why are things being done this way? So I want to just get your perspective as someone who comes in from the outside as a philanthropist. What role can you play? What voice can you have in addressing some of the things that, you know, we've all been raising here, and some of the known, you know, issues that cause inequities, problems with access, different quality, access to quality care?
Sure. You know, so far my role has been as an ambassador to certain organizations like Malaria No More or AMFAR, researching AIDS. And I think that, you know, adding my voice as an influencer in bringing awareness to people who can make donations, bringing awareness to people who can help with supplies has been helpful. But what I am recognizing is that as the conversation has elucidated, you know, a lot of politics gets in position, and it becomes difficult to really move the needle. Now, in the time that I've been an ambassador for Malaria No More, for instance, I've seen, you know, the rates of child death go from 1 every minute to 1 every 2 minutes, so halved. And that's because there has been a concerted effort in just lots of donations, new medicinal technologies, but also practices. You know, I wrote a song and made a PSA video about how to properly use your malarial nets, right? So that they're not being misused for fishing or for playing soccer as a goal or for, gardening, cordoning off your garden. There's that piece of the messaging. How do we get further? There is the stigma, as Dr. T was saying, about this gold standard for American regulatory, European regulatory for medicinal interventions. So in order for the world to acknowledge that science and development and discovery can happen elsewhere and can be just as viable, I think that's probably going to take elements outside of government structures. It'll probably require more of the kind of activity that maybe a Gates Foundation or a Rockefeller Foundation does, and then, philanthropy. The private sector, I think, could get involved. It makes me really, really think deeply about the kind of work that I'm doing with scientists in Houston, and I know that there are scientists everywhere who are just as talented and skillful at coming up with solutions. And if they had the kind of network and resource that I'm offering these scientists, then they could be the ones to push forward their solutions locally. And when people see a local transformation statistically, that could speak volumes, and not to have to wait for the saviors from imposing themselves upon everyone else coming from the West. That's how I'd answer your question.
But I think what you said about even, you almost said it in a dismissive way of like, I made a PSA, but I think that can be hugely powerful, right? As Dr. T was saying, because it addresses these social determinants like the cultural factors, the kind of embedded, stereotypes and thinking that people have about diseases, about health, and how to improve health. And I think those kinds of messages really probably resonate with people more so than doctors, either lecturing or giving messages. They probably have more impact.
I would hope that it does have more impact, and I think that there should be a communication, a dialogue between policymakers, between politicians, and then community organizers, and then artists, so that we can help translate. I love the role that I get to play in translating messages, and I want to be a voice to influence and inspire my peers to do the same, and especially not just in the same causes that get it's like all the oxygen out of the room, but we need to be prepared for future pandemics, and we should be paying attention to solutions that are not getting the kind of attention that they deserve.
So if you have some of your peers who come to you and say, Aloe, where can I help? Mm-hmm. What can I do? Like, are there certain conditions that you are starting to look at now that you feel probably could use to have a light shown on them?
I would suggest that it's not easy. I like to read a lot of the peer-reviewed scientific papers that are talking about the bleeding edge scientific technology, especially biomedical and biotech. I would suggest that they find an intervention that has promise to support personally, and with relation to this conversation, it has me thinking about reaching out to my contacts, let's say in Ghana, where I've been for malaria, but maybe a conversation about how would you be prepared potentially for the next respiratory pandemic, and in what ways could I be helpful? And maybe that's what it is we have access to the Western ears, but let's reach outside and see what we can do to be helpful without being patronizing for folks elsewhere.
One of the other sort of gaps that the pandemic really exposed was the sort of insufficiency in the mental health management system right now. And so Sheila and Maribeth, I wonder, particularly with the workforce and your teams, what challenges arose, and are you seeing our experience in having gone through the pandemic, has that changed the way that you deploy your teams, work with your teams, manage them in any way during crises?
I'll let you.
I can start. You know, I think having an existing mental health program is the key, so that then when there's a crisis, you can address that, but not have to start from scratch, obviously. I think we've had, just focusing on staff, I think our staff have gone through a tremendous amount. COVID in particular, we know the impact in the U.S. healthcare workers, but globally was the same and even more, probably as always, because of scarcity of resources. But I think we've focused on staff wellness. We also, for our patients in our communities, we utilize community health workers to be the front line in the community doing assessments of mental health. And part of the program has been kind of the task shifting of moving mental health into the community as a routine practice. So we're actually getting more and more people able to identify people who need to be referred up the system. I think if we're waiting for everybody to end up showing up at the clinic or the hospital, it's not going to happen, and it's also going to be, the volume will be so high. So I think building on an existing mental health structure, but then addressing the specifics of whether it was Ebola in 2014 and 15 in West Africa, when we utilized survivors to actually be those who went out and found people in the community. Same thing with COVID, people who survived COVID, we also utilized them to be out in the community trying to address and talk to people. But I think it is always, I think, trying to find who is the most, can have the most impact on those communities. And I think the front line of a community health worker is often those who are best placed. But then having a place to refer them, people who have challenges, up to a trained provider is the key. Community health workers by themselves are not a health system. They're part of an effective health system, but I think can be a strong component in the addressing mental health issues. And we're doing a lot of that in routine cases, but also during emergencies such as COVID.
I would just add that, I mean, the WHO estimate is that by 2030, the world is going to be short 10 million health workers. So somebody told me, if you want to get sick in this country, you should do so in the next 2 years, because the gap here is tremendous. And then we have these issues of migration of health workers, et cetera. But we're just not putting enough money into pre-service training. So the U.S. government puts money into in-service training, which is fantastic, but there's not enough money going into pre-service training. And then we saw during COVID, and if you know health workers in this country, the retirement of many health workers, we lost 280,000 health workers worldwide. That's the best estimate I've seen of how many health workers we lost. And you can't imagine it. In Ebola, I was just reading today that 8% of the health workforce in Liberia died during the Ebola crisis. So think of, taking 1 out of 10 health workers out of commission. That's what we're talking about. And if we really want to, we've got to support the health workers who are there. They need to be compensated. They need to be supported. We had mental health, but then we added a component of spiritual health. We come from a faith-based tradition, and that was really important to many of the health workers on the front lines in the countries where we were working, who have a faith tradition and who were seeing death all around them and putting their lives at risk, truly in a humanitarian way. So trying to think of what are all those things to help the people who are currently health workers stay in the field, but also to recruit the kinds of health workers we're going to need for the next 50 years. So.
And also thinking beyond probably the traditional health workers, right? And thinking more on the community level, the regional level, as all of you have talked about, and strengthening that infrastructure so that maybe it's like a lot of peer-to-peer help and support, particularly on mental health issues. But, just thinking beyond the traditional MD, yes, NP, and PAs, right? To say that, oh, you need a degree in order to be able to do this. Well, probably not. A lot of the tasks can be probably better delegated and more smartly delegated.
I should just say that this week there's a conference in Namibia on health workforce investment strategies. So I think it's the first time there's ever been a conference on the continent, very, very focused, with donors, with governments, kind of talking about what is our health workforce investment strategy, because the problem is so important and seemed to be exacerbated or highlighted during COVID. So.
Right, exactly. Okay, well, we have some time left. I wanted to open it up to questions for anyone in the audience who has a question for any of our panel members. Don't be shy. Yes.
Any, the eternal optimist, but any silver linings from COVID?
I think the fact that oxygen systems now are much more widespread is a huge silver lining that we didn't see. I also think we were asked to help we're a global organization, but we're asked to help in the U.S., and we're able to infuse the importance of social support into the Massachusetts contact tracing program, which, you know, it took a global look from what we do in Haiti and other countries to say you also have to be offering food if you're asking somebody to isolate. You know, a lot of the things that Dr. T was saying is not common in most U.S. responses. So I think we were able to infuse that, and some programs I think are starting to recognize more the need to push things into the community.
I'd just add to that, you know, potentially a silver lining is that we understand now how quickly the U.S. government can move in terms of creating new interventions,
When
right?
it wants to, right.
When it wants to, and so we know what the gap looks like, whether it's 10 years for a new medical intervention to reach the shelves, or it's 18 months. And it seems like we can use that knowledge to save more lives, whether it's a pandemic or it's chronic diseases that have been, you know, plaguing us for a long time. And we should, as citizens, be pushing our government to do more quicker, to save more lives.
Accountability, as Dr. T said, yes.
I'll add one too, which is, I mean, I'm an educator, right? So one of the things I've noticed is that we had more applicants to public health school across the country, right? More young people who recognize the implications for their lives. So in terms of what that means, I think that, and I've heard that in other countries as well, and I think that that's something, I still don't find it a lining, but it's a positive.
I would take it as a plus.
Okay.
I would take it as a plus, yeah. Mary Beth, you have anything to add?
I'm going
Okay.
to leave space.
Can I just add a follow-on
Yes.
to that? I'm just interested to hear from other panelists on this issue of the mindsets and the awareness of the next generation. I mean, as we get older, we talk about, oh, the next generation doesn't do this, doesn't do this. In some ways, it feels like they do have a different mindset around this issue globally.
And around, I think, accountability, right, as we've seen with the environment and on climate change, that's a great question. I wonder if anyone else has any thoughts they want to add to that?
I mean, I think that's very promising, people deciding to go into public health. I also know, like, dropouts from nursing school, still, it remains a problem globally. And sometimes they're dropouts simply because they don't have the resources to continue. So really thinking, like, what is it going to take when we have people who are dedicated, who want to serve, who want to think differently about what it means. I was thinking when you were talking about solidarity, about just those social justice principles that I think you can hear young people talking about. What does it mean to live in community? And I just was listening to the panel on education, and I was thinking, but the key thing, they were talking about what it meant for kids to go back to school. And kids missed community, they missed socialization, they missed so much. So we've got a generation of young people who are suffering from a whole lot more anxiety, et cetera, and that's a global phenomenon as well. But some of that has to do with, like, how do we take what they survived and then actually turn it into positive action to help them build community and get involved in things like public health or, yes.
The things about young people is that they're already leaders, right? And often we think about them as future potential to be harnessed, and they're leaders now, and we need to recognize their leadership now, today. And so for me, I think that's one of the important things, is to actually listen to young people, but also let their participation have consequence to what we do and the decisions that we make. And I think that's what I'm seeing more and more of, is very clear articulation of a vision, that a future we are co-visioning together, and we are just, and I'm not so young anymore, I call myself an elder youth. So as an elder youth, you know, I know that sometimes we find that we have all of these ideas and then we are just held back because you are not old enough yet, or you can't lead, or you can't do this. And so those artificial things that stand in the way. I think we have a moment now in various aspects, even outside of the healthcare topic, to really, value the leadership of young people in a way that previously perhaps has not been done. Yeah.
Okay. Anyone else? Yes.
Just following on that, I was wondering, in terms of your staff having this trauma and mental health, and often advocacy is seen as an outlet for addressing some of those, mental health and traumatic experiences and empowering for people. How do you, those of you who are working in country, how do you empower your local staff to get involved with these issues like environmental health and the systems that they're facing?
So we have a PH Engage chapters in the U.S., but also globally in Peru and Mexico. So that is young people who are garnered around the input for health equity, and so they learn how to work within the political system for advocacy, and how you work within the congressional system, how to do advocacy in the U.S. It's writing letters, it's Hill Days, it's that kind of thing. In Peru and Mexico, it looks different because the impact on the community is different. But there's a huge ask for this type of outlet, and so I think hopefully more and more this will come to play. But I think that the challenge has been the frustration then if things are not moving. And I think we're in Rwanda. We also have a University of Global Health Equity, and that's a very vocal, phenomenal team there and students there. But I think the challenge for a leader then is the trying to channel that in a way that we can try to make movement, but also understanding that politics get in the way of everything, and that I think can be frustrating. So how do we keep that in check?
Yes.
My question here relates to the politics part of it, the systemic underinvestment, which I thought was very fascinating how it was described. I come from a research background in biochemistry where we've had generally more funding than other programs in the humanities and public health. And I wonder about efficiency within research in public health, how y'all feel about the progress there, whether there is a sense of urgency to increase the efficiency of findings from research in public health to get out into the world. Is there a sense of urgency there? And who's sort of leading that charge?
Just on public health, there's a huge series from Kaiser Family Foundation on the systematic the dismantling of the U.S. public health system over the last 15, 20 years. So the data is shocking how little of the U.S. health budget, of the U.S. government's health budget, if you look across all parts of the U.S. government, not just HHS. I think the investment in public health is like less than 3% of the budget. So it's wonderful, the money that goes to the NIH, I'm all for that. We need more in CDC and on the science piece. But if you don't really have the public health systems at the county, and they were, talk about undermined in terms of their confidence. They were attacked for their work in public health. So we need a kind of rethinking and a re-energizing about what public health means in this country and what collective good means, because that's what I think we learned. Yeah.
I want to thank all of our panelists. I think it's clear we have a long way to go, but we saw some reasons to hope. So thank you very much.